Hello, everyone. My name is Megan Glenn. I am the National Assistant Director of Programs at the American Liver Foundation, and I would like to welcome you to today's webinar. The American Liver Foundation is the nation's largest nonprofit serving people with liver disease and their families. We provide a voice for patients with liver disease through education, support, research, and advocacy. I would like to thank Drs. Binu John and Jean-Paul Ashgar for joining us today and sharing their expertise. And thank you to Intercept for making this program possible. I just have a few housekeeping items. On the upper right-hand corner of your screen, you should see a dialog box. If you don't see it, there is an orange arrow where you can expand the box. From here, you can ask questions. You can ask questions at any time, and we will be answering them in the last 10 to 15 minutes of the webinar. We will get to as many questions as possible, and we absolutely encourage your participation. I would now like to introduce Dr. Binu John. Dr. John is the Assistant Chief of Medicine and Chief of Hepatology at the Miami VA Medical Center. He did his internal medicine residency, gastroenterology, and transplant hepatology fellowships at the Cleveland Clinic in Cleveland, Ohio, where he stayed on faculty for 4 years. Dr. John is now then went on to be Associate Professor of Medicine at the Virginia Commonwealth University and Medical Director of Liver Transplantation and Director of the Liver Cancer Program at the McGuire VA Medical Center in Richmond. Dr. John's area of research interests include hepatocellular carcinoma, liver transplantations, and outcomes in cirrhosis. He is a member of the Practice Guidelines Committee for the American Associations for the Study of Liver Disease and has served on the Clinical Research Committee of the American College of Gastroenterology. Dr. John, I will give you the slide.
Great. Thank you, Megan. Appreciate that. Can you hear me?
Yeah.
Okay, very good. So I want to thank the American Liver Foundation for the invitation to speak on this topic. Obviously, this is now a very interesting topic with COVID going on. There was a lot of interest in telehealth even before, but now with most of physicians and most practices doing telemedicine, it's caught on a lot of interest. And so over the next half an hour, I'll be talking to you about the data that supports telemedicine and telehealth in liver disease. And then Dr. Ashgar will talk to us about the nuts and bolts of how to take this technology and incorporate it into your practice. So I have no disclosures in relation to this talk. Okay. My slides are not moving. Can you advance the slide, Megan? Perfect, thank you. Okay, so as an outline of this talk, I'd like to first talk to you in general about two terms. One is telehealth and the other is telemedicine. We're going to discuss the data about impact of telehealth on outcomes of liver transplant referral. We're going to talk about telehealth and the management of patients with chronic liver disease and cirrhosis. And then finally, about using telemedicine in transplant evaluations and the data that supports that. Next slide, please. Great. So digital technology has completely changed the way we live. So even before COVID, online shopping is becoming very popular among all of us. And then online banking. So I've forgotten the last time I went to a bank. You either do digital e-transfers, you do mobile check deposits. And so a lot of face-to-face interactions have been replaced by digital technology. We have large e-commerce sites that deliver items to our house, grocery shopping, even before COVID-19 days had been moving online. And so digital technology has changed a lot of the way we live our lives. Next slide, please. But the one place that it had not made a difference was medical appointments and medical interactions, because the bedrock of our medical evaluations were face-to-face evaluations. So this is actually a study out of Harvard that was published in 2015 called the American Time Use Survey. So they surveyed 108,000 respondents between 2005 and 2013. And they estimated the amount of time it takes for an average person to actually go and see a doctor. And so this is average. So obviously in places like Miami, this is not the norm, but on an average, from the time it took for a person to travel to the appointment, to park, to wait to see a cashier to make the payment for their copay, and then wait outside in the waiting room, complete paperwork, see a doctor, and then check out. It took about 121 minutes. Out of this, only 20 minutes was spent actually face to face with the provider. And the opportunity cost that they calculated based on the sample in the survey was $43 for each appointment, which was approximately $20 for someone who earns $20 an hour. And as you can imagine, for many people who are attending this webinar, your opportunity cost for something like this could potentially be much higher. And so there was definitely major disadvantages to an analog system of medicine. Next slide, please. And so then we had COVID-19. And so overnight, Americans realized the limitations of the system of healthcare we had, because the old system actually had an incentive to support a face-to-face delivery. So there were changes in how you got paid. There were significant regulations that limited how somebody could incorporate telehealth into their practice. And because of all of these, the system actually discouraged telemedicine before COVID-19. Next slide, please. Next slide, please. Great. And so let's talk a little bit, like I alluded to in the beginning, the differences between telemedicine and telehealth. So a lot of what we do now, or what we see now, face-to-face interaction with clinical care of patients, is actually comes under telemedicine. And so telemedicine refers to the remote diagnosis and care and treatment of a patient using telecommunication technology. So that includes what we do with remote clinic patient visits, but it also includes things like teleradiology. So you patients undergo scans, those are sent remotely to radiologists in another state or even another country. Teleophthalmology, where patients come in for the annual fundus exam, pictures are taken and sent to a ophthalmologist or a retinal scan center in another state. Or even teledermatology, where patients come in, have abnormal skin lesions, those get photographed and then sent to a dermatologist who does not examine those in real time, but it's still the evaluation and treatment of a patient using this technology, and that all comes under telemedicine. Now, telehealth is a broader term. Telehealth actually includes not just telemedicine, but it also includes education, mentoring of physicians, and it's a broader term that also includes telemedicine. So what are examples? So what we're doing now, this webinar, is an example of a telehealth. It's long distance education and learning. What else is an example is tele-mentoring. So what we call the Project Echo or the Scan Echo program, where you have specialists sitting in specific hubs, reaching out to providers at smaller centers without specialist support. Next slide, please. Okay, so the VA was one of the first integrated health systems. So previous slide, please. The VA was one of the largest integrated health system in the United States. And so they were probably one of the earliest to incorporate Echo or telementoring into that system. And so what is a typical Scan Echo program? A Scan Echo program is a weekly meeting, virtual meeting of GI or hepatology providers, often with other specialists or with primary care physicians or mid-level nurse practitioners or physician assistant or trainees. And a typical session is about an hour, which includes 30 to 40 minutes of didactics on a specific topic in liver disease, followed by 20 to 25 minutes of discussions on cases. So centers that are involved in the Scan Echo program present complex cases to the Scan Echo center, and then specialists at that center can evaluate those cases and then give recommendations. And these providers then take those recommendations and then see the patient and incorporate it. So it's a form of telementoring that has been in the VA system for many years now. So next slide, please. So the first study that I'm going to describe here was the way we used a telehealth-based evaluation process in triaging patients for transplant. So this was, again, before I came to Miami. This was at Richmond, which is one of the 6 transplant centers in the US in the VA system. And so in the VA, liver transplant is done at one of these 6 centers. And so Richmond started a Scanico program for real-time consultation and transplant triage. So before someone actually sent a patient to us for transplant, we encourage these sites who are part of the Scanico program to first send these patients for a Scanico referral. And then the transplant center would give recommendations back to the center, and then they can make decisions about whether patients need actual transplant evaluation or whether they should wait. Now, so this was the diagram here. So on your right, on your left, you see the GI liver providers who referred patients through the Scanico program. So if you're a participating site of the Scanico program, you referred your patient to Scanico first. The transplant center reviewed, the hepatologist of the transplant center reviewed those cases and either decided these were non-candidates or these were potential candidates. And then all those patients who were potential candidates then underwent a complete liver transplant evaluation. And then after the package was submitted, they were either provisionally accepted or rejected. If they were initially accepted, then they underwent transplant evaluation with the full transplant team, and then they were either listed or not listed. If you were a non-participant at a Scanico center, again, this was if you were a participating site, you undergo a full transplant evaluation here, and then based on the determination of the center, you're either accepted or not, and then you undergo the same process. So half of the sites were Scanico participating centers, the other half of the sites were non-participating centers, and so we compared the difference in the evaluation process between the two. So we had 190 patients in the study. 91 of these subjects were through the Scanico center. The other 99 subjects were referred directly without the Scanico center. And what you can see is that the two groups were fairly well balanced in terms of baseline characteristics. Were predominantly in the 60s. These were predominantly male patients who were white. About half of them had decompensated cirrhosis. No differences between the two groups. The patients, about a third of patients had HCC within Milan. The difference was that HCC outside of UCSF or outside of OPTN was more common, commonly referred from patients not in the Scanico program compared to patients in the Scanico program. No differences in terms of average distance from the transplant center between the two sites. Now, what are the results that we found? We found that compared patients who were referred through a Scanico center, none of them were rejected at the time of initial transplant referral, compared to 41% of patients who were referred from a non-Scanico transplant center, referral center. Similarly, at the end of the whole evaluation, found that only 23% of all subjects from a Scanico center were turned down, compared to 56% of patients who were not referred through a Scanico center. Again, the reason why there were non-candidates differed, whether psychosocial, medical conditions, low MEL scores, no significant difference in the reason for any specific reason, but overall, we found that a large number of patients could have obviated the need for a full transplant evaluation if they had been initially triaged through a telehealth-based Scanico system. And so this was the data. We ultimately found that about 41% who were non-candidates could have been effectively ruled out initially using a program like this. It was helpful to minimize futile testing. It avoids unnecessary travel for subjects. It can potentially reduce costs. It reduces time and effort for referral coordinators at the referring center. So that was the data for the liver transplant triage. And so let's also talk a little bit about using the same telehealth-based technology in the evaluation of patients with chronic liver disease and management of patients with chronic liver disease. This also came from the VA, but this is from the Ann Arbor group. And what they did was they looked at all their subjects, all their patients who had a virtual consultation through the Scanico program, which was 513 subjects here. And they compared that with the subjects who did not have evaluation through a Scanico program. And then they used propensity score model to balance, even out these, compare these patients equally. And their primary outcome was overall mortality. And they also looked at other secondary outcomes. So this graph actually shows this is actually your propensity scores between the two groups. So on your y-axis are the various parameters that they compared between the two groups. On your x-axis here is the standard difference in mean between the two groups. So in other words, if your standard mean difference was between 0 and 0.1, it means that if you are in this group here, in this little rectangle here, you're fairly well balanced between the Scanico and the non-Scanico group. Whereas if you're outside it, as you can see, the bulk of these red dots here, it means there are substantial differences at baseline between the two groups. So as you can see here, prior to propensity matching, there are significant differences between the two groups. But once they found a propensity match control group, they're fairly well balanced with no significant differences between the two groups. And so once they did the propensity matching, here's what they found. The blue line here is the subjects who had a Scanico consult. The red line below is the subjects who had no Scanico consults. They found that there was a significant difference in mortality with the lower mortality in subjects who had a Scanico consults. The overall mortality at a 54% reduction, and they stratified this with subjects who had a high FIB-4 score suggestive of cirrhosis versus a low FIB-4 score subject cirrhosis without cirrhosis. They found that across both groups, there was a significant decrease in mortality in subjects who had a Scanico consult compared to those who did not. In terms of why they found that difference, they found patients who had a Scanico consult were more likely to have undergone HCC surveillance and more likely to have varicose surveillance. But again, these differences will not completely account for these fairly large differences in mortality. They also looked at the third group of patients, which are patients who actually saw a gastroenterologist or had an in-person evaluation. And they compared the Scanico group with persons who had an in-person evaluation, and they found that there were no difference. So this data suggests that a Scanico consult might improve, maybe associated with reduced mortality compared to patients who had no access to a gastroenterologist or a hepatologist. Again, there are limitations to the study because only 17% of the patients actually had cirrhosis. And so the benefit is unlikely due to cirrhosis care. About 40% of the subjects have chronic hepatitis C. So some of the mortality benefit might be from hepatitis C treatment. And I think a study like this is always a potential for what we call unmeasured residual confounding. But overall, there's a suggestion here that involvement of a specialist, either virtually or in person, is associated with significantly improved outcomes in patients with cirrhosis. So that's the data for the chronic liver disease and liver transplant triage. Now let's look at the outcomes in patients who actually underwent a liver transplant evaluation using telemedicine. So as we all know now, there's rapid uptake since March of telemedicine appointments across the country, but the VA has been doing telemedicine evaluations for many years now. And in 2011, the VA introduced an option to complete the initial transplant evaluation by telemedicine instead of in-person evaluation. So this adoption varied widely between the 6 transplant centers, with Richmond and Nashville being early adopters of telemedicine, whereas the other 4 centers took a little longer to adopt telemedicine into their practice. And so what we did was actually, well, what are the potential benefits of liver transplant evaluation by telemedicine? Obviously, the biggest difference is it improves access especially in patients who do not reside near a transplant center. As you all know, there are 145 transplant centers in the US, but most patients have to travel long distances to access transplant. And there are 13 states without liver transplant centers in the US. And many specialists travel long distances to reach out to patients where there are no transplant centers. So even outside the VA system, there are patients have to travel long distances to access liver transplant services. And so potential advantages of a liver transplant evaluation by telemedicine is that it could potentially expedite transplant evaluation and early access to a transplant team, and offer transplant as a safety net for patients who develop acute or chronic liver failure when they're referred with a low MEL score. So our data was actually it's just coming out in this month's CGH. So here are the two patient groups. Of all the patients who were referred for transplant, telemedicine was introduced in 2011 at the Richmond Transplant Center. And so we compared this group of patients who had in-person hepatologist evaluation between 2005 and 2011. That was before the introduction of telemedicine. And then we compared that with patients who had a transplant hepatologist evaluation by telemedicine, which is after 2011 till 2017. And we looked at the time from referral to evaluation. We looked at the time from referral to listing, as well as the time from referral to transplant. And then finally, we looked at the pre-transplant mortality, comparing these two groups. So a total of 749 subjects were referred, of which 416 patients were evaluated, 270 were approved and listed, and 186 patients successfully underwent transplant, of which 151 subjects were alive at the end of the study period. Here are the differences in baseline characteristics. As you can see, the telehealth group had 232 subjects. Persons who were evaluated in person, they had 233 in that group. And we found that subjects in the telehealth group was slightly older, 61 versus 57. Both had predominantly male and white population. MEL scores were slightly lower in the telehealth group. The MEL sodium scores were slightly lower, and a larger proportion of patients in the telehealth group had a MELD exemption, 22 versus 8% compared to the in-person group. So here are adjusted times from referral to evaluation. We found that patients from referral to evaluation, the telemedicine group had a 22-day interval from the time from referral to evaluation, as opposed to the in-person group, which is 80 days. The time from referral to listing was 139 days in the telemedicine group compared to 249 days in the in-person, and both of these were statistically significant. The time from referral to transplant was not statistically significant, so 325 in the telemedicine group as opposed to 409 in the in-person evaluation group. Now, what is most striking is the differences based on MEL scores. So as you can see, the blue line here are the patients who are evaluated in person. The red line are the patients who are evaluated by telemedicine. As you can see in the red line here, and the x-axis is your MEL score. So as you can see, the red line here is pretty flat. So regardless of your MEL score, if you're evaluated by telemedicine, you got evaluated pretty quickly. As opposed to the blue line here, if you evaluate in person, you waited a very long time if your MEL score was low, as opposed to if your MEL score was high. So there's a significant gradient here. And at high MEL scores, there were no differences between the two groups, but there were huge differences with low MEL patients, with telemedicine significantly shorter time to evaluation compared to the in-person group. Now this graph shows the time from referral to listing. Again, you see similar trends. When your MEL score is low, patients who were evaluated in person took much longer time to get listed compared to the telemedicine group, which was fairly flat. Once your MEL scores are in the 20s to 30s, we found there was not a lot of difference between the two groups in terms of telemedicine evaluation. And this is the time from referral to listing. Again, if you're at a low MEL score, time to transplant. If you're at a low MEL score, you're more likely to be transplanted faster. if you were in the telemedicine group. But once your MEL score crossed the 15 at the time of referral, the differences disappeared. So once, if you had a low MEL score, there was a significant difference, but overall, time to transplantation was comparable between the two groups. What about the pre-transplant mortality? Again, no difference between the two groups. Telemedicine group did not have an increase in pre-transplant mortality compared to in-person. So very comparable between the two groups here. So ultimately, the results of that study found, again, shorter time to evaluation, significantly shorter time to listing, no difference in the time to transplant, no difference in pre-transplant mortality. And so this highlights the significant benefits of telemedicine in transplant evaluation. So what about patient satisfaction with telemedicine? So this is a recent paper from the Penn group published in Gastro. They compared patients who underwent a telemedicine evaluation in the hepatology clinics at Penn, and they found that overall, this is a patient surveys comparing satisfaction with telemedicine compared to a face-to-face appointments. 73% of subjects felt that their satisfaction was the same, or they were equally as happy or happier with the telemedicine appointment compared to an in-person. So high satisfaction scores across the board. The majority of subjects felt that the technology was easy to use, was fairly high quality in terms of the actual experience, and they were overall very highly satisfied with the experience. Again, this was across the board, but there was differences between younger subjects and older. If you were younger, your satisfaction score was higher compared to if you were greater than 60. And again, there were differences between a telephone encounter versus a video, with a video face-to-face telemedicine encounter having highest satisfaction scores compared to a telephone encounter. What about the clinician satisfaction? 88% of clinicians rated the video visits as better or as good as a face-to-face, but only about 41% of clinicians rated the telephone as better or as good as face-to-face. But more than 80% of the providers was somewhat or very satisfied with the care they provided using telemedicine. What are some of the limitations they identified in that survey? They found that technology could be challenging for some patients, especially if you were older. They found that patients who were Black had more difficulty accessing technology in their study population. And of course, things like regulations, reimbursements, and licensure, which used to be issues before, but are hopefully changing for the better with COVID-19. What are provider challenges? Again, for many of you have now been using telemedicine in your practice for the last 3 months. I've been using this since 2015, and I find it to be a very satisfying personally. Patients love it. There's a very high patient satisfaction ratings with these. Obviously, there are things you need to learn. You know, at medical school and during residency, we'll learn bedside manners. With telemedicine, you have to learn website manners, which is essentially, some of these include looking straight into the camera, which you can sometimes forget, because especially if your camera is located at a different level compared to your screen. And so when you're looking down on the screen as opposed to the camera, patients can sometimes feel that you're not looking at them. And so those are some of the things you need to learn while you incorporate telemedicine into your practice. What are the benefits of telemedicine for practices? Again, major benefit is access and reaching underserved populations to increase the potential pool of patients and therefore more revenue. It offers more affordable care services. It strengthens patient relationships. And many of you might have noticed when you do telemedicine or telephone encounters, your no-show rates dramatically drop. There are very few patients who no-show for their appointments. What are the benefits for the patients? Obviously, not having to travel for an appointment in terms of time, in terms of cost, not waiting as long compared to an in-person visit. And for some patients, not paying as much, not worrying about a shortage of local specialists, especially for rare conditions, including liver transplantation. So in summary, we have shown you some data that telehealth improves access to care. It's definitely more convenient for patients, more convenient for their families. It's got potential advantages for centers to expand their reach to more patients outside of their local areas. And it's more convenient for providers for outreach. There are many transplant centers that reach out or travel out from their local cities to access patients for transplant in remote areas. And this involves less travel for patients like that, for providers like that. We also showed that sorry, the slide's frozen here. Megan, can you advance the next slide, please? Okay, we also showed that Scanico, we actually showed data here where a remote telehealth-based program is associated with reduced mortality in care of patients with cirrhosis. We showed you the data on Scanico triages where a remote triage by a specialist can identify non-candidates and improve access for patients for transplant and minimize futile testing. And then finally, we showed the benefits of telemedicine, where it can significantly reduce time to both evaluation and listing without a negative impact on pre-transplant mortality. And these benefits were significantly higher for patients with the low MEL score. So with that, I turn over to Dr. JP Ashgar, and he'll be talking about the next part of the talk.
Thank you very much, Dr. John. I would now like to introduce Dr. John Ashgar. Dr. Ashgar is a staff physician at the Cleveland Clinic in the Department of Gastroenterology, Hepatology, and Nutrition. He specializes in inflammatory bowel disease and holds the Kenneth Rainin Endowed Chair for IBD research. He has helped to lead the transition to telehealth visits in his office. Dr. Ashgar, I will give you the control.
Thank you, Megan. Thank you, Binu, and thank you to the American Liver Foundation for this invitation. So as you heard, I'm not a card-carrying hepatologist, but I've had a lot of experience at our institution, a big institution with setting up and dealing with this whole transition of telehealth, and have not by choice, but learned a lot about documentation and billing and requirements and things like that. And I will try to impart some of the things I've learned as we've done this transition in the next few minutes. Megan, it's not advancing for me, so if you could get me my next slide. So interestingly, just a mere 3 years ago, the topic of telehealth deserved a review article in the New England Journal of Medicine. And this started with a definition of what telehealth is. Megan, if you could advance the next slide, and had a nice color figure of the different options related to telehealth, whether it was clinician to clinician, clinician to patient, or mobile health technology for monitoring purposes. Next slide. However, prior to the pandemic, as some of the things we heard about from Binu, there have been limitations to telehealth use, and we were not a big user of telehealth prior to March 2020. And why was that? Several reasons, including reimbursement issues, which often served as a disincentive for providers to pursue telehealth. And this relates to differences in state and other regulations with reimbursement. So many, but not all states prior to March 2020 required insurance to cover telehealth. And amongst states where there was a requirement to cover telehealth, there was state-to-state variation in payment parity with in-person visits. And what I mean by that is in some states, a virtual visit that included a video component could be reimbursed at a similar level as an in-person visit, but in other states, there was a less of a financial gain for a virtual visit compared to an in-person visit. In addition, there were concerns with HIPAA and whether the platform one was using was HIPAA compliant. Variable patient access to technology, as we've heard. And there were also geographic limitations for practices across states. So in our area in Northeast Ohio, we have a catchment area that includes Western Pennsylvania and Eastern Michigan. And so in telehealth, I would be practicing across states. And if I wasn't licensed in Pennsylvania or Michigan, that would limit what I can do. Next slide. In addition, from a Medicare standpoint, prior to March 2020, Megan, if you could advance the slide, Medicare would only pay for telehealth when the patient was in a designated rural area and the patient physically went to a clinic, hospital, or medical facility that had a video setup with which they could connect with the physician or provider for that telehealth visit. Next slide. In 2019, Medicare started to cover virtual check-ins, which were short, patient-initiated video communications with a healthcare professional. Next slide. And more recently, there were Medicare Part B would cover e-visits, which were non-face-to-face patient-initiated communications through an online patient portal. Next slide. So this was our practice. Oops, okay, that's okay. This was our practice prior to March 17th, 2020. So the tan bars are in-person visits and the green bars are virtual visits. So you can see how at a large institution with a pandemic, on a dime, we very quickly turned from a predominantly in-person practice to a predominantly virtual telehealth practice. In addition, next slide. In addition, things were ripe with these growing options for video-based platforms, some of which I've listed here, that were coming online and some of which quickly modified the things they do to be more compliant around this time. Next slide. So when the pandemic hit, there were rules and reimbursement that limited us, but there was technology availability. And in early March, there was this bill that was passed through Congress with a waiver. Next slide. And what this did is allowed, it was called the Coronavirus Preparedness and Response Supplemental Appropriations Act with the 1135 waiver authority. So a big mouthful there. But basically what this did is allowed Medicare to pay for office, hospital, and other visits via telehealth across the country, including the patient's place of residence. So if you remember, previously Medicare required the patient had to travel to a certain facility. Now a patient was allowed to be at their house and do a virtual visit. It also expanded the range of providers able to provide telehealth services, including doctors, advanced care providers, psychologists, and social workers. And it also allowed flexibility for healthcare providers to reduce or waive any cost sharing, copays, or any other cost sharing issues that may come up for patients for these telehealth visits paid by federal healthcare programs. Next slide. Subsequent to this, so this was early March, there were then subsequent amendments issued by the federal government that include relaxation of HIPAA rules and allowed for the use of multiple platforms for telehealth visits, including some things that aren't HIPAA compliant, such as FaceTime. There were waiving of federal licensing regulations, so gave providers the ability to treat patients in different states via telehealth. And it also allowed for payment parity, both for video visits and subsequently for these telephone audio-only visits. Next slide. So the current menu of Medicare telemedicine visits includes telehealth visits, which are defined as interactive audio and video telecommunication with real-time communication with the patient. And Medicare allows these currently to be considered the same as in-person visits and to be paid at the same rate as in-person visits. The next category is telephone visits, defined as audio-only visits. And as I mentioned, initially these were limited, but with the subsequent amendments, payments were increased to roughly match those similar to office and outpatient visits. And there's still the option, which was there before, of e-visits, which is online messaging initiated by patients. Next slide. So these are tables which you should, hopefully in the back of your minds, be familiar with. So these are the standard billing requirements and coding requirements for an in-person new patient visit. And so we're all familiar with these. We've used these for years. We've had our coding people send us messages that we didn't meet the level 4 billing and that they're downgrading us to a level 3 billing because we didn't meet all the requirements. But with these waivers and amendments that were issued by the government, now we can apply these same billing levels for virtual telehealth visits, so the video and audio component. And importantly, and I'll talk about this in a little more later, there are two components to this. Most of us used the 3 out of 3 components of the gray barred listed areas, the history, the exam, and the medical decision making. But what's been present for many years is there can be time-based billing, which my suspicion is many of us don't use for in-person visits, but the time-based billing may lend itself a little bit more when we're talking about telehealth visits. So that's new patient visits. Next slide. And how does Medicare reimburse us for these new patient visits? Again, this is nothing new, but is important to consider when you're deciding about in-person versus telehealth visits. So these are, I left the website at the bottom there. You can search these for any area. I'm listing for you what in Ohio we get reimbursed for new patient visits, level 1, 2, 3, 4, and 5. What are the RVUs? What are the non-facility prices? Non-facility is defined as an office location visit, whereas facility would be an ASC or a hospital-based visit that you're conducting. And for the most part, you will find that as you go up by an increment, there is about a half of a point increase in work RVU, except in the new patient going up from level 3 to level 4, there is a full point in work RVUs that you go up. Next slide. Similar to this are the established patient coding and billing requirements. And for established patients, we only require 2 out of the 3 gray bar components. So you could do a history and medical decision making, and as long as you have those requirements, you don't necessarily need an exam to bill at a level 3 or level 4. But you also have the option for time-based billing with established patients. And again, for telehealth, you can apply these rules and use them. Next slide. And then the other thing that's come into our menu of options are telephone-based visits, so audio only. Sorry, before that, these are the RVUs and reimbursements from Medicare in the state of Ohio for what you would get for level 1, 2, 3, 4, and 5 established patient visits. And again, as of June 2020, these apply to both in-person visits and telehealth video plus audio visits. Next slide. And so the other menu of options that is available to us is a telephone audio only visit. And as I mentioned, there is a temporary increase in the reimbursement for these visits. These are time-based only. That is the only option when you're doing a telephone visit. You can only bill based on face-to-face time spent with the patient. And you can see whether you spend 5 to 10 minutes, 11 to 20 minutes, 21 to 30 minutes, RVUs and reimbursements are listed there. And there is also an option that if you exceed 30 minutes, you can combine the above codes. So for example, a 45-minute visit, you would combine both a level 2 and a level 3 visit, a 30 plus a 15-minute visit to get you to that 45-minute telephone visit only. Next slide. So some tips, and go to the next slide, tips for documentation. So again, as I mentioned, I'm going to show the new patient billing slides, but these comments apply equally to the established patient. You have the choice of doing either history exam and medical decision-making billing or time-based billing. Next slide. Let's talk about time-based billing because that may be relatively newer or we're not as familiar with it. Next slide. So time-based billing requirements, we can only bill for time spent face-to-face or on the phone with the patient using these codes. There are other codes for chart review and things like that, but if we're using these codes, we can only count for the time spent face-to-face. The requirement for this is that more than 50% of the time must be used for counseling and coordination of care, and the nature of that counseling or coordination must be documented. So a statement, a typical statement would be, I spent 30 minutes, a total of 30 minutes face-to-face with greater than 50% of that time spent counseling regarding diagnosis and treatment options, including risks. Next slide. The other option is to stick to the standard history exam and medical decision making. Now there's an extra layer of complexity when we're doing that via telehealth. Next slide. But these can be done, and we have tried to mimic the flow for our in-person visits. So how do you update medications, past medical, past social history, review of systems? You could certainly, if you have the luxury to set it up, use the same methods that you use in your in-person clinic. An MA can contact the patient prior to the visit and update medications, allergies, review of systems, fill out questionnaires, or walk the patient through some of those things. Alternatively, if you have another provider, an advanced practitioner, a resident, or a fellow working with you, they can also assist with getting some of this documentation done. Next slide. What about a physical exam? So for the new patient visit, if you want to bill without using time-based billing, you will need to have a physical exam documented. And there are 12 organ systems that are considered as part of the physical exam. And I've got them listed there: constitutional, eyes, ear, nose, and throat and mouth, cardiovascular, respiratory, GI, GU, musculoskeletal, skin, neurologic, psychiatric, and hematologic. Next slide. And to bill at the higher levels for a new patient, you need to document examination of 8 organ systems. So this is an example of a virtual physical exam that you can use with a camera and asking the patient to hold the camera or move their head close to the camera or move certain body parts close to the camera. That can be done. So general and psych are fairly straightforward. Eyes, we can have the patient move their eyes close and pull their eyelid down to examine the conjunctiva. We can ask them to move their eyes left, right, up, and down to assess extraocular muscles. Ears, nose, and throat, I've given you some examples, but I've had patients put their mouth up to the exam. Now this is to the camera to try to examine the uvula or the mucous membranes or dentition. It's a little trickier. You may want to ask them to shine a light in their mouth from their iPhone as they're trying to do that if they have a separate webcam. Skin, hard to do a full skin exam, but you can, do you have rashes? We can try to assess for jaundice via virtual. Next slide. Other things that can be done, you can do rough approximations of a respiratory exam by assessing breathing, asking the patient to take a deep breath, do things move up and down symmetrically. Cardiovascular, we can look for evidence of cyanosis. We can ask them to show their lower extremities to assess for peripheral edema. Abdominal exam, here they either have to point the camera down or stand up. And depending, ideally, if we can get them to pull their shirt up to examine for things like distension, incision, or scars. But even if we don't have them pull their shirt up, I've done an assessment where the patient palpates along their abdomen and they tell me whether they're feeling any sensation of tenderness or discomfort. And finally, neurologically, certainly from a liver standpoint, we can assess for asterixis, and we can do simple things with sitting, standing, walking to assess grossly the neurologic exam. So this is just an example. Obviously, you can tailor this to what makes sense to your own practice, but it would be an example of an acceptable virtual physical exam that can be done. Next slide. So what is my approach? And I'm just going to, having done lots of these now, as I'm sure many of you have, but with particular attention to kind of billing and coding requirements. So again, I take care of patients with inflammatory bowel disease, a chronic illness where patients are on immunosuppressives and biologics that require monitoring of blood tests and drug levels, and where I have to pay attention to health maintenance issues. So hopefully this sounds fairly familiar to you and what your practice is, and these things can be applied in your practice. Next slide. So what I found for me, for an established patient first, so if I'm by myself, I've actually found that by the time I've gotten through all the things that I want to get through, checking their labs, the drug levels, health maintenance issues, for a straightforward visit, a patient that's doing well, I've already spent 15 to 20 minutes, which gets me to a level 3 billing. And at that point, if I'm happy that that's kind of covering the gist of that visit, I'm not going to worry about doing a physical exam and or going back and documenting past medical history and review of systems if I don't already have those things documented. And for a more complicated patient, again, I find that I'm getting up to 20 to 25 minutes of time that I've spent. And again, I feel comfortable billing based on a time visit. Now, if you're more efficient than me and you're hustling through and you can cover a complicated patient in 15 minutes, you can then consider, do you really want to do the exam, the history exam and medical decision-making based billing. If I'm with a resident or fellow, so for those of us who work at academic centers, again, remember for time-based coding, I can only count the time spent face-to-face with the patient. So if I spend 10 minutes reviewing the chart, 15 minutes listening to the patient, presenting the patient, and then I'm on the phone with the patient or on the video with the patient for only 5 minutes, I can only bill for a 5-minute visit. There's some tricks around that. You can have the fellow present in front of the patient and things like that. So some workarounds with that. But the nice thing with the fellow is we can ask the fellow to document some of the history, exam, and other findings that then will allow us to bill at a little bit of a higher visit. For telephone, audio only, remember this is only time-based billing, so you can only count the time that you, the staff provider, is spending on the phone with the patient. So it makes it a little bit trickier there. Next slide. For new patients, on the other hand, and we heard from Binu how video-based visits are preferred both by patients and providers. So this is where I really try to push as much as I can for video and audio visits. And ideally, as I mentioned earlier, try to use a similar workflow as what I do in in-person visits with the MA documenting and charting, and I try to use history, exam, and medical decision-making. Next slide. And the other question, so this is June 2020. Where are we going to go in July, in August, and September? And there's a lot that's not known of this. There is a lot of lobbying going on, and there are some bills being introduced in Congress to continue to support some level of telehealth visits. I don't think we will be at this level that we are now, nor do I think we will be at the level we were at before March 2020. I think we will settle down somewhere between those things. I do think that probably telephone audio only visits will drop off our menu of options. There will be a disincentive to providing those. But I'm hoping that the virtual, the audio and video visits there'll be an incentive to continue those. And just, I listed some examples there of what's listed on the websites of some commercial insurers. So Aetna has the cost sharing waiver has gone away, and the telephone visits will be covered only until August 4th, 2020. And then you can read the rest of those, what other providers are doing. Next slide. So in summary, telehealth is here to stay. There will certainly be further coverage issues in this evolving landscape. And I mentioned already the telephone visits. And then the problem with this, again, is there likely will still be state-by-state rules and variations, and there will be commercial insurers coverage variations. So keeping on top of all of this stuff will be important. But at the base of it, remembering what is required for your documentation and billing requirements will be the key. Thank you.
Thank you so much, Dr. Ashgar. Let's now read the questions. We do have a few. So the first question is, we think of MELD as being a determinant of who gets a transplant before someone else. Is this research showing that telemedicine can now make receiving a transplant sooner, even with a lower MELD score?
So that's a good question. So the MELD scores that I presented to you was the MELD at the time of referral. So it does not change the MELD at which patients get transplant, but it's the MELD at the time of referral. So what's the potential benefit of using telemedicine to expedite that evaluation is that if you have a patient hovering around a MELD between 10 and 15 and is doing okay, so you have two options. You can either expedite that evaluation and list that patient sooner, or you can wait till the MELD goes up into the 20s and then evaluate the patient. Now, the benefit of listing the patient sooner is that if there's an acute event that they suddenly decompensate, then you are not pressed for time because there's a possibility that patient could deteriorate quickly and you don't have the time to complete the evaluation and they might die before you successfully transplant them. So the rationale or the benefit, what I believe that showed in the study is if you evaluate patients sooner and you list patients sooner with low MELD scores, if they develop acute or chronic liver failure or they develop an acute decompensation, then you stay out of the curve. And so that's where the benefit is. So that MELD is not at the time of transplant, but that's at the MELD at the time of initial referral to the transplant center.
Thank you. The next question is for Dr. Ashgar. Is the anticipation that the amendments Congress made to ease the use of telemedicine, will they become permanent, or is it more so something that was just used for the COVID-19 crisis?
Correct. So these came under this Emergency Act. So they will not be permanent. When the Emergency Act expires, these things will go away. But as I mentioned, there are other bills or propositions that have been put out in Congress to continue to some level these visits. My best guess is that there will be a push for virtual visits, video plus audio, to continue to receive payment parity, i.e. the same as in-person visits for Medicare. Now, whether commercial insurers will pick that up or not would also be a factor. And my guess is that the telephone visits will drop off. I don't think we're going to get continued high-level reimbursement for telephone audio only visits.
Okay, thank you. That is all the questions for now. If you do have any additional questions, please email us at education@liverfoundation.org and we will reach out to Drs. Ashgar and John to get those questions answered. I want to thank Dr. John and Dr. Ashgar for taking the time today to share your expertise. Thank you to Intercept for supporting this webinar, and thank you to everyone for joining us today. Dr. Ashgar, Dr. John, do you have anything to add before we come to a close?
No, just a thank you.
Thank you, everybody.
Thank you so much. With that, we'll bring the webinar to a close.